Today I am going to examine your thorax and lung.
Begin your examination by inspecting the thorax and lung. Now ask the patient to breathe in, breathe out. Count the number of breaths per minute. Normally, a resting adult breathes easily, quietly, and regularly about 14 to 20 times per minute. Inspect the patient's neck for these accessory muscles suggesting respiratory difficulty. Palpate the sternal notch to check the position of the trachea. It should be in the midline. Check the patient's color for circumferal and nail bed cyanosis. Now examine the posterior thorax. Now palpate the chest wall to locate any area of pain or tenderness or lesions or bruises suspicious for rib fracture. To test chest expansion, place your thumb close to the patient's spine at the level of 10th rib. Place your finger slightly across the lateral thorax. Ask the patient to breathe in and breathe out. Now we can see the diverge of thumbs, normally about 2 centimeters. Now feel for the vibrations of tactile firmness as the patient continues repeating 99. Here, use ball of your hand and identify the area of increased, decreased, or absent firmness. Continue the examination by percussing the chest, a systemic manner, moving down the thorax and going from side to side as demonstrated in a ladder pattern. Remember that only the distal interphalangeal joint of flex cremator finger should be in contact with the chest wall. Wrist motion should be relaxed and fluid as you make strikes with the tip of the third flex. Here we are trying to transmit vibrations through the bone of the flex cremator joint to the underlying chest wall. Now ask the patient to breathe out and use percussion to identify the lower level of diaphragms. Ask the patient to take full inspiration and measure the dissect of the diaphragm. Excursion is usually 3 to 5 centimeter. If we hear abnormal bronchial breath sounds, assess transmitted voice sounds while osculating in the chest. Again ask the patient to repeat 99. Louder sounds reflecting transmission through airless tissue is called bronchopnea. Next test for ecophy of E to A change which occurs in lobar consultation from pneumonia. Now ask the patient to repeat E. Normally, we will be hearing a muffled long E sound. If the underlying tissue is consolidated, the E changes to a bleeding E.
1, 2, 3.
Finally, check for whispered pectoral. Now ask the patient to whisper 1, 2, 3. Whispered voice is usually heard faintly or indistinctly.
1, 2.
Examine the anterior thorax by patient lines. And now palpate the chest to locate any areas of tenderness or to assess any lesions or abnormalities. Then access the chest expansion. Feel for the extent and symmetry of the respiratory movement. Next, palpate for tactile firmness. Compare both sides of the chest using the ball or ulnar surface of your hands. Phragmitis is usually decreased or absent over the precordium. Next, percuss the anterior chest and the lateral chest. The heart usually produces an area of dullness to the left of the sternum from the third to the fifth interspaces. While percussing with the right, percussion progressively steps downward in the right mid-clavicular line. Auscultating the patient anteriorly and laterally, ask the patient to breathe with the mouth open. Compare the symmetric areas of the lung using the lateral pattern suggested for percussion. Listen to the breath sounds, noting their intensity. Identify any adventitious sound and if indicated, listen for transmitted voice sounds.
9, 99.